It should be clear by now that not only is the conviction of Lucy Letby an utter debacle, but also that it could so easily have been prevented. In this video, we're going to examine 20 different ways in which this calamitous prosecution and miscarriage of justice could have been avoided. Number 1. The Countess of Chester may not have downgraded staffing for the neonatal unit in what were cost-cutting measures. I outline the full extent of this in my book, but it's very clear that the Countess of Chester downsized and downgraded staff beginning many years before the perfect storm that occurred on the neonatal unit between 2015 and 2016. This was one contributing factor that led Michelle Warden to tell The Guardian that incidents on the unit during this period were simply an accident waiting to happen. Number 2. There might not have been a massive NHS maternity crisis in the first place. NHS maternity services have been under sustained pressure for years. That pressure shows up in waiting lists, closed or downgraded labour wards, vacancy rates for midwives and senior obstetricians, the growth of short-term agency staffing, and a relentless tempo of high-risk transfers between hospitals. This is critical background context that underpins the £60 billion of negligence claims in the NHS that have been reported recently. How does that systemic stress translate into worse outcomes for newborns? There are several connected mechanisms. The first of these is staffing mismatch. Neonatal care is highly labour intensive and depends on experienced teams. When units run with too few experienced nurses, rely on agency staff who don't know local protocols, or lack sufficient senior consultant cover, the margin for error narrows. Complex resuscitations, subtle deterioration, or rapid sepsis can be missed or managed suboptimally because the team is stretched or unfamiliar with one another. Secondly, increased case mix and transfers. Maternity pressures, closed delivery suites, bed shortages, or temporary service changes push more high-risk pregnancies and very premature babies toward fewer receiving centres. That concentration of sicker infants raises the raw numbers of poor outcomes, even if each child receives competent care, simply because the clinical risk per baby is higher. Thirdly, continuity and escalation breakdown. When the same mother sees different teams across antenatal, delivery and postnatal care, warning signs can be lost in handovers. Busy units with hurried handovers and fragmented notes make it harder to pick up small but important trends in a baby's condition, trends that, if caught early, can prevent catastrophe. Fourthly, training and supervision suffer. Overstretched services deprioritise continuing professional development and simulation training. Junior staff may be left to make decisions beyond their experience without ready senior backup. That's a classic recipe for avoidable harm, not because clinicians aren't committed, but because the system hasn't given them the conditions to be reliably safe. Fifthly, infrastructure and infection control. Pressure on space and bed flows forces creative compromises, bays used beyond capacity, difficulties isolating infectious babies, and delays in cleaning or engineering fixes. Those environmental problems increase the risk of outbreaks and rapid deterioration in vulnerable neonates. Finally, culture and morale matter. Chronic understaffing and burnout blunt clinical curiosity and escalate threshold. Teams become increasingly resigned to just getting through, rather than interrogating why outcomes are worse. That normalization of risk delays escalation and learning. A documented systemic crisis provides multiple non-criminal pathways to clusters of poor outcomes. Staffing, transfers, continuity, training, infrastructure, and culture are all relevant. Any fair and indeed legitimate causal analysis must place those mechanisms front and centre, not as distractions, but as plausible evidence-based explanations that deserve rigorous independent examination before leaping to individual culpability. Indeed, all of the problems mentioned in this section were evident at the Countess of Chester Hospital. Number 6. The Countess of Chester Hospital's neonatal unit may not have agreed to take a particularly challenging tranche of babies. This is a crucial point. In neonatal care, not all babies are created equal from a clinical risk perspective. A sudden influx of very premature, very low birth weight infants, babies needing complex post-operative care, twins, triplets, and babies transferred from other hospitals because of capacity problems will change the pattern of outcomes, and dramatically. We don't know if the Countess of Chester was asked, pressured, or obliged to accept a heavier than normal load of high-risk cases. We just know that makes an enormous potential difference to outcomes, even in a competent unit. Sicker babies should be routed to the nearest available specialist centre. Those babies are, by definition, more likely to have complications and indeed poor outcomes. A cluster of such transfers over a short period can make a normally performing unit appear to be experiencing a spike in catastrophic cases, when in reality it's simply treating more high-risk patients, and in this case treating them suboptimally, and that's being generous. The mechanisms that push patients around are administrative: ambulance decisions, referral pathways, capacity pressures, and even local policy changes, for example, temporarily closing delivery suites or diverting in utero transfers, can concentrate risk. Were there policy changes, bed pressures, or systematic diversions at that time? We may never know the full picture, but those operational facts would go a long way to explaining a concentrated rise in bad outcomes without invoking any form of deliberate harm. And naturally, staffing and specialist cover interact with care mix. If a unit suddenly takes on more complex patients but does not have proportionate consultant and neonatal transport team resources, along with simply space, outcomes can deteriorate through no malicious intent, simply because the system is overstretched. Transparency about admissions and transfer logs is therefore essential, and this simply hasn't occurred with the Countess of Chester Hospital. No one truly knows why this small, inexperienced, inadequate, incompetent unit was given such a challenging tranche of twins, triplets, vulnerable infants, and babies that quite clearly required level 3 care. The recent FOI request of Mark Mays has made this even more clear than it was already. Had this been recognised on the unit at that time, or even in the Northwest region, the debacle of the prosecution of Lucy Letby could have been stopped. Number 4. The Countess of Chester Hospital's neonatal unit could have been run more competently. The public evidence gathered for the Thirlwell inquiry makes it crystal clear that this was a unit under serious pressure, short of senior cover, with nurse staffing that did not meet requisite standards. Those shortfalls are documented in inquiry material which explicitly finds nurse staffing on the neonatal unit did not meet British Association of Perinatal Medicine and Royal College guidance. That would be troubling anyway, but is magnified by the acuity of infants on the unit. Pressure produces predictable harms. The inquiry's internal documents, and documents indeed from the hospital, illustrate the fact that the unit had periods of higher than expected mortality alongside a rise in acuity, more very sick babies, at the same time as staffing and operational strains were being repeatedly recorded. Those same papers note that the complexity of care and the pattern of shifts and part-time cover created fragile working arrangements. This is indeed the primary reason that Lucy is on the unit so much and works extra shifts. Multiple contemporaneous reports and media reports have uncovered further operational failings, chronic shortages in doctors, over-reliance on junior and locum staff, infection control concerns, and physical infrastructure problems that made safe isolation and barrier nursing difficult. These appear in an array of internal documents from the Countess of Chester. When you have understaffing, gaps in senior decision-making, variable training in emergency responses, and inadequate facilities for infection control, mistakes multiply and outcomes deteriorate because the system cannot reliably deliver the complex high-risk care that these babies needed. We should also be clear about the scale. Dozens of unexpected collapses and deaths during 2013 to 2016 were re-examined, and only some of these were subject to police investigation, a tragic signal that things went badly wrong clinically, regardless of any so-called criminal investigation. The inquiry documents list the numbers of these events and show that they took place against a backdrop of continual operational strain. What follows from all of this from a sceptical perspective is the following. Poor management and resourcing are credible, non-criminal explanations for clusters of catastrophic outcomes. Staffing rosters, consultant availability, training gaps, infection control, and physical layout all materially affected mortality and morbidity on the unit. Additionally, any fair assessment must separate institutional failure from individual blame. If care was delivered in an under-resourced, overstretched environment, then failures of management and governance, inadequate escalation, poor reporting, and weak quality assurance systems are far more plausible drivers of avoidable harm than a single malicious actor who no one saw do anything wrong. Again, this could have been identified at the time, but it was not. Number 5. The Countess of Chester Hospital's neonatal unit might have had better sanitary conditions and infection control. It is undeniable that there were persistent plumbing failures on the neonatal unit, raw sewage backflow from sinks, frequent drain incidents, and chronically low water pressure that made effective hand washing difficult. These weren't one-off anecdotes. Plumbers were called repeatedly, and staff raised hand washing and contamination concerns at the time. That matters hugely because vulnerable neonates are uniquely susceptible to waterborne and environmental pathogens. The hospital record and expert community cited in the attached material point to confirmed or suspected cases of sepsis across multiple infants during the same period, and to documented colonization of taps with organisms such as Pseudomonas, a bacterium known to form biofilms in pipework and to cause severe, often rapidly fatal infections in premature babies. Practical consequences almost inevitably followed. There are examples at the Countess of Chester of delayed recognition and treatment of infection, antibiotics given late, missed, or ambiguous monitoring, and babies who improved after transfer to other hospitals only to deteriorate again on return. Clinical teams repeatedly noted sepsis as part of the differential diagnosis, yet in court, almost all of that infectious context was either downplayed or excluded from the narrative. In short, 3 linked failures are clear: environmental contamination via sewage and tap colonization, limitations in basic infection control infrastructure, low pressure, cramped layout, aging fabric, and shortcomings in clinical detection and response to sepsis. Any one of those could raise mortality and morbidity in a neonatal unit. Together, they create a highly plausible systemic explanation for clusters of collapses and deaths that does not require deliberate harm by a single individual. There are also troubling institutional signals. Inspection notes that inconsistently recorded these risks, infection risks that appear on local risk registers but that received limited public traction, and expert commentators who argued the unit should have been closed or more vigorously investigated, once sewage and Pseudomonas were identified. All of this collectively suggests that the infection story was hugely underexplored in court. When raw sewage, waterborne superbugs, repeated sepsis, and other infections are documented in the same place and period, infection control failure is a serious evidence-based explanation for clusters of neonatal collapses and deaths. Any fair assessment of causation and of whether criminal acts played a part must treat those documented sanitary and microbiological hazards as central, not peripheral or non-existent, to the story. This could all have been addressed at the time on the neonatal unit. It was not. Number 6. Consultants on the unit might have reflected on their own actions and errors instead of instantly blaming Lucy for everything. Let's keep this point simple. There were a catalogue of errors made in the treatment of twins and triplets on the unit. Care for child C was little short of calamitous. The most basic errors were committed in the avoidable passing of child D. Other infants on the unit could and should have been saved. Basic procedures were repeatedly bungled. Did any of the consultants reflect on any of this? Of course not. Number 7. The hospital could have paid heed to the Care Quality Commission and Royal College of Paediatrics and Child Health reports from 2016. The Royal College of Paediatrics and Child Health carried out an invited service review of the Countess of Chester Neonatal Unit in 2016, and the Care Quality Commission inspected the trust in the same year. Those external reviews were specifically examining governance, case review processes, staffing and safety, exactly the levers that, if acted on, would have changed the shape of the response to collapses and deaths on the unit. Infamously, the RCPCH cited a lack of ward rounds on the unit. What is less well known is that the Care Quality Commission documented that other departments at the Countess of Chester were conducting the quantity of ward rounds that should have been taking place on the neonatal unit. It seems explicable that this was not taking place. The 2016 invited review urged thorough independent case note review, strengthened network support and improvements in governance and handover processes, along with an enormous raft of other required improvements. And this is despite the fact that it's clear that the Royal College wasn't given the full picture regarding the unit. A mature consultant body would have reflected on this and assiduously considered their role in the deaths and collapses of infants, along with the contribution of poor conditions and care on the unit. Again, this did not happen. Number 8. When Dr. Murthy Saladi wrote to the other consultants, indicating his concern and asserting that the police should be contacted, this could have occurred. In June 2016, a consultant at the Countess of Chester Hospital, Dr. Murthy Saladi, wrote the following: "We have investigated these deaths as much as we can, which included seeking clinical input from outside. The only thing which came out of it, as I understand, is one member of staff was working in the unit, not necessarily with the baby who passed away in each incident, but might have cared for the baby during the staff breaks at the time of all these deaths. This is highly unreliable information, and further outside clinical input is unlikely to help shed more light on the relevance of this information. However, we seem to be acting on this unreliable information. This is unfair to the staff under suspicion, unfair to parents and other staff who are unaware of the situation, and unfair to the staff who are aware of the situation." Saladi called on the situation to be referred to the police immediately and for the consultants to accept that they could be suspects. I assume this didn't happen because Dr. Brewery and Dr. Jairam didn't want to be suspects, and nor did they want to be whistleblowers. Had this occurred at the time, Dr. Dowie Evans would likely have never turned up, and the whole farcical investigation may have been avoided. Number 9. Lucy could have been placed under supervision, as was suggested. When visiting the County Chester Hospital in 2016, the RCPCH review team were told that when the neonatal lead made allegations to management, the Director of Nursing considered supervised practice for Lucy, but the consultants would not accept this and required the nurse to be removed from the unit. Senior operational staff on the unit reported being very upset at the situation, and the neonatal nurse manager in particular explained the difficulty of wanting to support Lucy and managing morale and anxiety amongst the other nursing staff who were not aware of the allegation. Had Lucy been allowed to stay on the unit with supervision, it is certain that this calamitous prosecution would have been prevented. Number 10. Lucy could have claimed constructive dismissal. Having had all 7 points of her grievance procedure upheld in the latter months of 2016, Lucy could have opted for constructive dismissal. Considering that she had been accused of murder without evidence and removed from her post without good reason, she would certainly have had an excellent case. Indeed, lawyer Ian Pace advised the hospital that the best case scenario for the County Chester would be Lucy seeking such a constructive dismissal, indicating that this would be less financially punitive than legal action from parents. Unfortunately, Lucy was passionate about her work and wanted to return to her profession and the County Chester neonatal unit. Had she simply filed a constructive dismissal, she would never have been prosecuted. Number 11. Dr. Breary and Dr. Jayram, in particular, could have engaged in whistleblowing to medical organisations rather than insisting on police intervention. This is a very simple point. By now we have seen how badly Cheshire Police mishandled the investigation. There was little justification for referring the matter directly to the police in the first place, particularly given that there was no clear evidence of criminal wrongdoing at that time. If consultants on the unit were dissatisfied with the conclusions of medical investigations by pathologists, coroners and neonatologists, the appropriate next step would have been to seek further scrutiny from an independent, credentialed medical body, not law enforcement. Criminal investigation should be a last resort, not a default response to unresolved clinical uncertainty. Had there been deeper, properly constituted medical review of the deaths, much of the information later uncovered by Barrister Mark MacDonald's panel of neonatal experts could have been identified at the time. That would have allowed clinical, systemic and environmental explanations to be explored thoroughly, transparently and proportionately without prematurely reframing a medical problem as a criminal issue. Number 12. Executives at the County of Chester could have refused to refer the case to the police and insisted on another medical body being involved. Just to add briefly to the previous point, while executives at the County of Chester were initially resistant to a police referral, they ultimately folded under pressure from the consultants. It appears that figures such as Ian Harvey and Tony Chambers believed that the police were unlikely to investigate, and indeed that would probably have been the case had Dr. Breary and Dr. Jayram not attended Chester Police Station themselves. Nonetheless, it is clear that Dr. Breary and Dr. Jayram did not have the confidence or authority to initiate a formal referral independently. As a result, responsibility ultimately rested with the Trust's executive leadership. Had the executive team refused to refer the matter to the police, the criminal investigation could have been avoided altogether. In that scenario, further medical and systemic investigation, rather than law enforcement intervention, would likely have remained the primary route for addressing concerns. It seems highly unlikely in this scenario that the findings of pathologists, coroners, and 2 examining neonatologists would have been overturned. Number 13. Cheshire Police could have not so readily and uncritically accepted the word of the consultants and decided to fully investigate quite so rapidly. We've discussed many times on this channel that Cheshire Police had no intention of opening an investigation, viewing the case as largely exhausted and unsupported by evidence, until the intervention of Dr. Breary, Dr. Jayram, and to a lesser extent, Dr. Susie Holt, on the 15th of May 2017. Following that meeting, Cheshire Police appeared to perform a complete 180-degree turn, rapidly announcing the launch of a criminal investigation. This clearly should not have happened, and definitely should not have happened that quickly. Number 14. Other lines of inquiry could have been fully explored by Cheshire Police. There were numerous other lines of inquiry that Cheshire Police should have pursued. In particular, they should have approached the consultants with the same level of scepticism that they almost immediately directed towards Lucy Letby. Instead, key professional assumptions went largely untested. Cheshire Police also failed to investigate the full background to the grievance procedure at the Countess of Chester Hospital, an omission that could have revealed critical context, motives and internal dynamics that were hugely relevant to the case and situation at the Countess of Chester Hospital. Dr. Steve Watts, who has already been interviewed on this channel, has described a range of basic errors committed by the police during what can only be described as a shambolic investigation. Fundamental investigative steps were not followed, standard procedures appear to have been ignored, and alternative hypotheses were not meaningfully explored. The result was a chronically biased and deeply flawed investigation. Number 15. Someone competent could have been called in to assess the medical notes, as opposed to Dr. Dewi Evans. While British legal history contains its share of dubious expert witnesses, it is still difficult to imagine that any clinician other than Dr. Dewi Evans would have attended a police briefing and concluded that deliberate harm had occurred within such an implausibly short time frame. Any competent, independently minded medical expert engaged by the police should have identified the numerous obvious clinical problems affecting the infants. Because of the involvement of Dr. Evans, the case ultimately presented in court took on a distorted and at times frankly farcical character. Number 16. Cheshire Police could have engaged in a quiet process behind the scenes without running straight to the press and generating immediate headlines. It is staggering that just 3 days after having no intention of investigating events at the Countess of Chester Hospital, Cheshire Police had not only decided to launch a full investigation, but had publicly briefed the Guardian newspaper about it. One immediate and unintended consequence was that Dr. Dewi Evans became aware of the case. Had Cheshire Police conducted any preliminary inquiry quietly and discreetly, Dr. Evans would likely never have become involved, and that alone could have prevented the prosecution of Lucy Letby. A more appropriate approach would have been for the police to proceed cautiously and privately, first gaining a proper understanding of the clinical and organisational context at the Countess of Chester, identifying all legitimate lines of inquiry, and deciding whether a criminal investigation was justified at all. Instead, by evidently rushing into a high-profile public investigation, Cheshire Police effectively confined themselves to a single hypothesis, which was deliberate wrongdoing. From that point on, the investigation appears to have focused entirely on attempting to prove malfeasance rather than neutrally testing competing explanations. There were more mature, professional and competent ways for the police to proceed if police involvement was necessary in the first place. Unfortunately, this did not occur. Number 17. Cheshire Police could have listened to the National Crime Agency and appointed a panel of experts who would have overruled Evans. I had long since suspected that Dr. Dewi Evans effectively took control of the medical direction of the investigation, advising the police on how to proceed, and that Cheshire Police lacked either the competence or the confidence to challenge him or hold him to account. The reality now appears even more troubling. We know that the National Crime Agency advised Cheshire Police to establish a multidisciplinary panel to conduct the medical review. Cheshire Police nevertheless allowed Dr. Evans to advise that no such panel was necessary and that he should proceed alone. That should clearly never have been permitted. Allowing a single expert to provide the sole medical input in a complex neonatal investigation was a serious error of judgment by the police. That would apply if Dr. Evans was either a practicing doctor or indeed a neonatologist, both of which do not apply. We also know that when Lucy Letby was first arrested, Dr. Evans was the only clinician who had reviewed the medical notes, a fact confirmed by Paul Hughes of Cheshire Police. This combination of over-reliance on a single expert and the absence of independent medical scrutiny represents a profound investigative failure, and one that cost Lucy Letby dearly. Number 18. Even leaving aside the ignoring of this advice, Cheshire Police could have sought a second opinion from another expert, as well as seeking the views of other neonatal nurses. Everyone is familiar with the basic principle of seeking a second medical opinion. It is common sense, and in complex or uncertain cases, it is standard practice. Yet despite being advised by the National Crime Agency to involve a multidisciplinary group of specialists, Cheshire Police failed even to obtain a second independent medical opinion. Had another expert reviewed the medical notes independently, which never happened, it is highly likely that they would have reached conclusions very different from those of Dr. Evans. We can say this with considerable confidence because since the trial, dozens, if not hundreds of clinicians across multiple specialties have examined the case, and I am not aware of a single one who has endorsed any of Dr. Evans' conclusions in full or even in substance. Number 19. Cheshire Police could have hired Professor Jane Hutton, ignoring direction from the Crown Prosecution Service. Cheshire Police's decision to discontinue engagement with statistician Professor Jane Hutton, having initially contacted her and requested her assistance, can only be described as inexplicable. It is particularly troubling given that this appears to have occurred at the direction of the Crown Prosecution Service, a body that should not interfere with the conduct of a police investigation. Professor Hutton's involvement would almost certainly have exposed fundamental weaknesses in the statistical assumptions underpinning the investigation and by extension the entire prosecution case itself. Although she did not ultimately participate in the police inquiry, Professor Hutton has since become a forthright critic of Lucy Letby's conviction, a position she articulated very clearly in her interview on this channel. Number 20. The Crown Prosecution Service could draw on actual expertise and be an organisation that is fit for purpose. Finally, it is difficult to hold the Crown Prosecution Service in high regard. This is particularly true given its undue interference in this case, instructing Cheshire Police not to engage Professor Jane Hutton. But even leaving that serious issue aside, the organisation routinely fails to involve appropriately qualified or credentialed professionals when assessing cases of complexity and significance. The Crown Prosecution Service relies on a standardised, cookie-cutter approach to criminal cases. One of its two main considerations is whether a prosecution is in the public interest. In a case such as that of Lucy Letby, it is almost inevitable that the Crown Prosecution Service will conclude that a prosecution is in the public interest if the evidential threshold is deemed to have been met. In reality, this effectively reduces their process to a single step, evaluating the quantity of evidence. The Crown Prosecution Service lacks the scientific and medical expertise necessary to assess such evidence adequately. Had doctors, scientists, nurses, statisticians, and other experts been involved in reviewing this case, the decision about whether to proceed to court could have been entirely different. In summary, it should be crystal clear by now, Lucy Letby's conviction represents not just a contested verdict, but a cascading failure across clinical, managerial, and law enforcement systems. And it was a failure that could so easily have been averted with multiple opportunities to do so. The story begins with the NHS system. The counter suggests that downsized and downgraded neonatal staffing for years, a chronic resource squeeze that turned the unit into an accident waiting to happen. More widely, an NHS maternity crisis involving closed wards, vacancies, agency staff and frantic transfers concentrated higher-risk infants in the Northwest region in fewer centres. If the unit was asked or obliged to accept an unusually heavy tranche of extremely sick or premature babies, outcomes would naturally worsen, even without any form of misconduct. Those structural pressures, staffing, transfers, continuity breakdowns, training deficits, infrastructure limits, and collapse in morale are plausible evidence-based causes for clusters of bad outcomes. Operational competence, infection control, and clinical care were all far from optimal on this neonatal unit. Local management and clinical practice was critically important. The Thirlwell inquiry and internal papers document inadequate senior cover, poor rosters, and frequent operational failures. Physical infrastructure was poor, plumbing failures, low water pressure, and documented Pseudomonas and sepsis contamination created a real infection risk, environmental pathogens that can kill vulnerable neonates. Numerous basic clinical errors were recorded on the unit. Consultants largely failed to reflect on those errors instead of instantly attributing blame to a single nurse. Together, poor management, infection hazards, and clinical lapses formed a coherent, non-criminal explanation for the spike in deaths, but one that was never investigated. Multiple opportunities to resolve the situation without criminalisation were missed. External reviews from the RCPCH and CQC urged independent case note review, better governance and network support, but these advice were not acted on. Consultants could have escalated concerns to medical bodies or accepted supervised practice for the nurse under suspicion rather than pushing the case straight to the police. Executives could have resisted pressure to refer the matter to law enforcement and pursued deeper medical investigation instead. Lucy could even have pursued constructive dismissal, but she wanted to keep working. Had any of these management or professional routes been taken, the trajectory towards a prosecution might have been stopped. Cheshire Police changed course dramatically after consultant referrals and rushed into a highly public criminal inquiry. They accepted consultant assertions too readily, failed to pursue alternative lines of inquiry, including a full examination of the hospital's grievance processes and operational context, and made basic investigative errors. They allowed a single expert, Dr. Dewi Evans, to dominate the medical narrative, ignored National Crime Agency advice to set up a multidisciplinary panel, and declined to obtain robust second opinions from independent clinicians and neonatal nurses. That combination of haste, deference, and lack of independent medical scrutiny created the perfect conditions for what was an incredibly flawed prosecution. A truly independent, credentialed medical and statistical assessment was never properly secured. Dr. Evans' solitary role was never adequately checked by other experts. Cheshire Police initially contacted statistician Professor Jane Hutton, but then mysteriously dropped her involvement, reportedly at the direction of the Crown Prosecution Service. Professor Hutton's independent statistical review would very likely have exposed serious weaknesses in the assumptions underpinning the case. The Crown Prosecution Service compounded the problem. Rather than drawing on medical, scientific and statistical expertise for a complex neonatal case, the Crown Prosecution Service applied a cookie-cutter approach, focusing on quantity of evidence and public interest without the specialised analysis that this situation absolutely demanded. That institutional error made a prosecution far more likely than it ever should have been. This was not a single error, but a chain of avoidable failures, system stress and bad infrastructure, poor local management and missed clinical learning, a rush to criminalise instead of investigating clinically, over-reliance on one expert, failure to assemble multidisciplinary review, and a prosecutorial process that lacked the requisite expertise. At multiple points, staffing decisions, infection control, independent reviews, alternative professional routes, second opinions, and a more sceptical private policing approach, the crisis could have been diffused, and Lucy Letby would still be a free woman. If these structural, managerial, and procedural failures had been addressed, the prosecution of neonatal nurse Lucy Letby would never have happened. Lucy Letby continues to pay a colossal price for incompetence, stupidity, ignorance, and gargantuan systemic failure.